So some key takeaways before I review parts of the disposition table itself. What I want AMEs to take away from this is we're talking about garden variety depression anxiety here. That's what the word uncomplicated is referring to, which has actually more specific reference in terms of psychology to those without significant mental health risk factors, such things as suicidality, psychosis, bipolar disorder, et cetera. I'll go a little more into detail on that. It allows you to clear those type of conditions under some limitations, um, but allows them to be in psychotherapy at the time that they see you for the exam. We want to encourage treatment. This includes even previous monotherapy with antidepressant treatment that is two years or older. The other key, takeaway from this is, again, it allows you to clear certain things at your level that we're finding is not it's either no risk or low risk that we feel, and you guys have that a judgment at your ability to make that assessment, that safety risk assessment for the duration of the medical that you provided them. Next slide. So this kind of summarizes on the left-hand side. Dr. Fraser put these nice bullets on the left side, and this is just a partial snapshot on the right side of the disposition table itself. But there's 11 conditions, which we'll review in subsequent slides, but it allows you as the AME to clear up to any 2 of these conditions. Again, they may have been on some type of medication usage, but that can have been within the last 2 years, with one very, very technical exception to that, which I'll review in another slide. And of course, they had to have been treated. That's the key. That's another big key takeaway of this uncomplicated anxiety, depression, and related conditions disposition is that they sought treatment and received treatment. We're not asking you to evaluate necessarily the quality of the treatment. They had to have received some benefit, but we're not asking you to chase down the diagnosis. That's what's critical. As you can see in this disposition table, we're not requiring you guys to provide documentation. You have to make a special notation in block 60 for our analysts to understand that we don't need to ask for documents. Of course, as an AME, it's your prerogative if you want to obtain documentation, and certainly that may be the case in some cases where the airman can't provide the adequate history to your satisfaction. But again, I'll review those conditions and how you would go to row B. Next slide. So it can be up to 2 of any of these 11 conditions. As you can see, we kind of group them into 3 generic categories for purposes of this disposition table: anxiety, depression, and other. As you might see, we have situational anxiety added now as a condition, as its own condition. We also have as its own condition situational anxiety and depression, or what's in the DSM named as adjustment disorder with mixed anxiety and depressed mood. As you may also notice, we have 2 conditions in here, which we already have disposition tables for: situational depression and PTSD. We still have those disposition tables in the AME guide. And specifically for situational depression, this is the one technical exemption, so to speak. If an airman had situational depression as one of the conditions and was on some type of medication within the last 2 years, you could use that disposition table instead of this one, but it's only for that particular condition. In other words, AME could choose either or of these disposition tables for that particular condition, and then use this disposition table for another listed condition here. We've also made changes to the PTSD disposition table to reflect the changes in this disposition table. And I won't go review those changes with you, but basically it allows them to be in psychotherapy currently or within the past 2 years. And the decision tool that's in the PTSD disposition table is basically linked back to the one in here. So they're one and the same. And I'll review that decision tool here in a second. Next slide. So that last condition that was called the V codes, or in the ICD-10, we call them the Z codes. These are some examples, but it allows you to use the AME to clear these in a similar manner under these conditions. So it's not uncommon that individuals go to therapy for these conditions, but unfortunately, because of insurance or billing purposes, the therapist has to put an additional code under here other than a V code, but the purpose of the therapy is really to address one of these V codes. So we're hoping this disposition table allows you to to clear some of those individuals that may get diagnosed with things like situational anxiety, situational depression, when really the primary diagnosis would be one of these V codes. Next slide. So I want to go in a little more detail on the decision tool. This is what allows you to be able to clear somebody if you have everything in the no column. And these are basically the kinds of things we call excluders that we want you to defer. So as you can see, number one, that's getting to a lot of the specifically disqualifying conditions. We're also having other named conditions that if you have any concerns for, even the likelihood airman is being guarded, not giving you a complete history, telling you whether they had ADHD, at some point, this would be the area where you check yes, and you'd have to defer. If they happen to meet the fast track requirements for ADHD, and you did a workup for that was congruent with fast track for ADHD, and they met one or two of the other conditions under this disposition table, you'd be able to issue. But the standard track ADHD, you'd have to defer. Of course, things like suicidality, homicidality, involuntary evaluation, psychiatric hospitalization, other treatment modalities that you get on history, they've been to TMS or had ECT, those kind of things, you'd have to defer. Number 6, if you have any suspicion that they've had more than one episode of symptoms in their life, whether it's spaced out over a period of time or just more than once, that would be an indication to defer. Obviously, we include some of the last 3 things in this decision tool to give you guys the ability to understand this is something really that's needs to be that's incompatible with safety flight related duties. Remember, you're looking at the duration of the certificate for what you're issuing. This would allow you to defer if you're not comfortable. Let's say you think that there's still some amount of symptoms that needs to be further assessed. This is the tool that allows you to defer that. For right now, we're not allowing you to clear past history of multi-agent drug protocol use, but that's to come with certain conditions. And of course, any medication usage in the last 2 years with that one technical exemption or exception I noted with situational depression, if you use that other disposition table and it meets the conditions of that disposition table. And of course, as in many of our decision tools, number 9, if you do get documentation or have evidence from the mental health specialist, treating clinician, or just you as the AME, have some concerns about the history or exam, this would allow you to defer it as well. Next slide. This is just the same things I just described. We're not requiring you to submit this decision tool, but you may if you like. Next slide. So of course, in the instance that you need to defer, you would have to follow row B. So right now, if you encounter somebody who's previously been on a special issuance under our old SSRI, what we now call our antidepressant protocol, you'd have to defer. If you have suspicion that they have major depressive disorder, dysthymia, even single episode, you'd have to defer. Any history of dual or triple therapy, defer. And when you defer, this would assist us in being able to determine if we could give a warning or a special issuance of some type, is obtaining a detailed clinical progress note and sending that in as well. Next slide. So as you can see, just to summarize what I've talked about, because I know there's going to be a lot of questions to go over. We're talking about garden variety anxiety and depression. We know many airmen may not know their exact diagnosis. I want you folks to be less centered on running down the exact diagnosis and more about looking at the decision tool and looking at those things that we call the risk factors and would exclude them from issuing them. But we want to encourage early treatment. So this decision tool is to encourage those to come forward, say, yes, I'm getting treatment. This is what it is. They're in therapy. You think everything else is fine. It meets the decision tool. We'd like you to issue. We're not requiring you to issue. If you feel you're not comfortable, of course, you can defer. But this is a way to encourage folks to seek out evidence-based therapies. And of course, defer individuals that might have risk factors so we can do further workup. Next slide. Before I take questions, we do have a new 9 box here for our psychiatry branch at headquarters. This is for all of you. Airmen themselves can also use this, but this helps me to triage requests, making sure that we can get back to you in a timely manner. If you prefer a callback, just state so in the email. But we're monitoring this now, so.
So we're going to talk about cardiology updates. So the cardiology updates, there was a cardiac roundtable that the medical appeals physicians led by Dr. Bendrick and the federal air surgeon cardiology consultants had in April. They made quite a few suggestions, and those suggestions are what we're going to go over, recommendations rather. One of the big highlight items was removing the requirement for a stress test once an AASI has been issued for cardiac conditions, CHD, coronary heart disease, coronary artery disease. So that's going to be helpful to your pilots because they won't have to get a stress test for a routine AASI. They'll just need to be able to make sure that they have risk factors modified, and we'll go over how we need that done. The next item that the panel addressed was, do we need a stress test for somebody who's had a cardiac valve replacement or a valve repair? And again, that answer was no. So that's been removed from the initial cardiac valve and cardiac valve repair or replacement protocols. Pacemaker was the next topic. Pacemakers are still an SI. They still have to have a every 6-month pacemaker summary. What used to happen is at 18 months, their annual special issuance or special consideration dropped down to 6 months only. And then when they had 6 months of battery life, they were grounded until they had the battery replaced. The cardiology panel went through pacemakers, and kind of the quote from the panel was, the most reliable thing in the cockpit is the pacemaker because they work well, they're efficient, they can see how well they're performing. Because of that, they thought it was safe to go ahead and issue an annual special issuance for pacemakers until the month before the estimated replacement interval. So that kind of replaces the battery life. Next one is cardiac conditions. They talked about the fasting blood sugar that we've required for a long time. It's not as accurate as an A1C, and A1C gives a better range. So any place that we used to ask for a fasting blood sugar for cardiac conditions is now an A1C. And then we did get some questions about, can we use some of these other types of EKGs other than a 12 lead? We'll go over that in just a second. So the big ticket item, this is the updated AASI for coronary heart disease. You will see in that second box under authorization for the FAA, the only thing that is required is a coronary heart disease, coronary artery disease recertification status summary. So it used to be a detailed clinical progress note from the cardiologist and some type of stress test. The goal is to have their risk factors controlled. So if their risk factors are controlled, all they have to give us is a coronary heart disease research status summary. There's certain items where you'll have to defer. You're an AME, if you see somebody who's had a new incident, somebody who's had a new MI, somebody who's had a new stent, if they get bleeding that requires intervention, chest pain, they have to be placed on nitrates, anything like that, you would defer. But a routine AASI, we only need one document submitted. Remember, this is only for research. Initials still have to go through the process. So first and second class coronary artery disease, those are all run through panel. Third class is reviewed by the medical appeals physicians. And then if they have questions, they send those through panels. So what we're talking about for this research status summary is only for once they've had an AASI. All right, so this is the document the medical appeals physicians came up with. The cardiologists have looked at it and they thought it was covered what we need. The first number 1 instruction says if you do not have a current special issuance for CHD, stop. If you don't have a special issuance, you don't need to use this. You need to send in the information that's on the protocol pages. But if they have a valid AASI and in some cases an SI, we need 6 questions answered from their cardiologist. We'll highlight a little bigger in just a second those 6 questions. But in the middle, top middle of the page, you'll see the references. Those are the references that we're using to identify what is considered under good risk factor control. We do want blood pressure, we do want LDL, and we do need an A1C. So how you as an AME would look at this, give it to your pilot takes it to their cardiologist answers those 6 questions for us, dates and signs it. When you're looking at it, if everything falls into the yes column or the left-hand column, and you do not have any concern, then you're going to be able to go ahead and issue a recert AASI. So left column, all yeses, you can issue the recert. So people are asking, well, when is it an AASI and when is it an SI now? So AASI is when their risk factors are controlled, there's no residual concerning CAD, and they don't have any symptoms. In most cases, if those criteria are met, they're going to be issued an AASI. If they don't make the AASI, if their risk factors are not controlled, if they've got symptoms, if they've got residual disease, those will be case by case as a special issuance. If they have a special issuance instead of an AASI, we still are going to need a progress note from the cardiologist. If they have the status summary, that helps, that speeds everything up from our end. And then there will be some type of stress test in most cases. But again, that's for the SIs. So use an AME. If it's an AASI, all you need is the research status summary. Question we had yesterday is, are pilots going to be notified about this change? We're going to hope that you can help us do that when you see your pilots. If they can avoid having a stress test, if they don't need one, then that'll save time and money. We do need them to get this document to their cardiologist, though, so the cardiologist can answer those questions for us. All right, next condition, pacemakers. Again, pacemakers were thought to be very, very reliable. We've gotten rid of the 18-month requirement for a special issuance. So now if the estimated battery life, previously, if the estimated battery life was more than 18 months, it was an annual. Once they dropped under 18 months, it was every 6 months. And once they had less than 6 months of battery life, they were grounded. Now, pacemaker is an annual special issuance. They can stay on the special issuance until the month before their estimated replacement interval. So if their estimated replacement interval is in July, their special issuance will be good until June 30, so last day of the month. Pacemaker status summary was updated to reflect that, to show that the ERI interval is what we're looking for. But important things for your pilots is it means that they don't have to sit down when they have less than 6 months left. However, if they have exceeded the ERI, and that would probably be very uncommon in private practice, but if they have exceeded their ERI, then they would have to, then they would be grounded. All right, next item. Valve repair and valve replacement. Both of those initial protocols required a stress test. That item has been removed. So initial valve repair, initial valve replacement, they do need an echo, they do need a Holter, they do need the information from their cardiologist. They no longer need a stress test. Next item, we did get a phone call about some of the new EKG gadgets that are easily obtained. And the question was, can you use a 1-lead, 2-lead, or 6-lead EKG for the required EKG for first class? And that answer is no. The standards were all set using a 12-lead, and the standards were set before all the new technology came out. But right now, if somebody needs an EKG for any reason, if it's because they're first class, they're 50, 55 years old and they need their annual EKG, or if they need an EKG because of a cardiac condition, or we ask for an EKG, it does have to be a 12-lead. And then we also, as we talked about, removed the fasting blood sugar requirement on the CVE. You'll hear about the CVE all the time, and replace that with an A1C because it was a better measurement. All right, so changing gears, we have a couple of kind of odds and ends. One is GI. So gallbladder disease, we just expanded the disposition table a little bit. It's symptomatic or asymptomatic. If they're asymptomatic, they had surgery, no complications, we want you to just go ahead and issue. If you can, put the date of the surgery and if they had any complications or not. Make sure they're off of all their pain meds, and then just issue. If they have symptoms, if there's some kind of surgical complications that is still existing, then that's when you would defer. All right, next we're changing to ophthalmology. We're seeing a lot more cases of lattice degeneration. We've talked to our FAST consultants about lattice degeneration, and we understand that it's being identified more easily now because of the cameras. They get better pictures. Once it's identified, it's often followed in clinic, and so that's potentially why we're seeing more. If it's regular, if it's uncomplicated lattice degeneration reported by the individual or it's on the progress notes, if they don't have flashers, floaters, decreased vision, blurry vision, and they meet vision specs, you can go ahead and issue. The big question you probably want to ask is, did you have laser or did you have some type of surgery on this lattice degeneration? If you did, if the pilot did, they will drop down into row B. So row A is uncomplicated, it's been noted, maybe they're being followed, but no procedure. If they do have symptoms, they had a procedure, they don't meet standards, they drop into row B. The row B standard request is a letter from the eye doctor. In this case, it can be ophthalmologist or optometrist. We do need their visual acuity confirmed, and then any other testing that was done. You'll notice on here our standard ask out is for medication. We know that this is something that's treated with laser or surgery, not medication, but we want to make sure they're not on any other eye meds. All right, a couple other miscellaneous items. In the neurology section, the neuro section was completely updated January of 2023. So one of the items was brain tumor. We used to require that they see a vascular neurologist. They can see their regular treating neurologist. The letters and blurbs have all been updated to address that as well. And then in admin, we did have some comments from AMEs that on the AMCS site, the limitations for the certificates were in numerical order, but it made it difficult to find out, well, where's all the ones for color vision and time limitations? So this document that's in the AME guide is just for your reference if it makes it easier for you. It's grouped by system. We're moving the guide more to system-based, so all the cardiology is in one place, all the neuros in one place. This is just a helpful reference. The official version is in AMCS, and it is listed numerically. But if you need help trying to find out which one, this just sets it up by system. And with that, this is the final plug we always put in for how can we improve the AME guide. We want to thank everybody who's already given comments. We're trying to get some of those items worked in so that it can be faster and easier and more efficient for you to be able to do your job. We know there's a lot of changes that are coming at you, so we want to make sure that you can find the information.
I appreciate the comments in the chat regarding that this has been helpful. We are definitely looking forward to doing these more. We've got some ideas that are just being really fleshed out that I'm not going to share yet, but more to come in this space. And I know there are some comments from the 400 folks on how to make sure you get your CME. Did you want to go over that real quick, Deanne King?
Absolutely. So that it was Gary, I'm going to ask you to put that information out. There he is. He's on ahead of me.
Gary's good.
I know. Okay, so Gary just posted in the chat about receiving your CME. So there's the email address to you. When this session is over, please send an email just with your name and your AME number to, if you're not an AME, but you're a doctor, put that note in there too. And that we will compile that list to send out CME certificates. If you're not in, that way we have your email address and everything so we can send those certificates out. If your name in this, on your profile here on your picture, says something like iPhone or iPad, or one says 999447, we don't know who you are and we can't verify your attendance. So if you didn't change it, like we asked at the beginning, then you're going to have to include whatever that name is in that email so that we can cross-reference and know that you attended this session. That's a requirement for our accreditation, that we verify attendance. So please do that and send to that email address. And we appreciate you being on, and our plan is to continue this. So look for more emails in the future about future sessions.
No, ma'am, I'm good. And I want to thank everybody for participating and good questions this evening. And as Dr. Northrup said, we hope that this is an acceptable forum for you guys. We're pretty excited about it, and we will continue on with this forum. And again, it's good to see you guys. Thank you so much.
All right. Well, everybody, thank you for your time. I know for those of you on the East Coast, it's well past, or at least my bedtime. As I once reminded a bunch of people I was chaperoning, hey, listen, you may not need your beauty sleep, but I do. So we do appreciate the interest, and watch the space. More to come.